Hello, Daniel. Welcome to the show.
Hey, Will, thank you so much for having me on. I'm a little intimidated by your past guests, but I'm so excited to be here, kind of talk about my experience and especially my experience with neuroimaging and at the aiming clinics in particular. So thanks so much for having me on.
Oh, it's awesome to have you, and I'm really excited about this conversation. I've been looking forward to this for a while. You have a, from what I can tell, a profession inside of psychiatry that's pretty unique, and not a lot of practitioners are working the way you are in the aiming clinic, and also some of the more integrative aspects of that work that I think I didn't know about on the face of it, of how things are done there. So I'd love for you to just introduce us to how that, what that practice setting is like for you, what kinds of um, tools you all are deploying there. Who's a good referral for that kind of setting, what you like about it. I'll just let you riff on it.
Oh no, that's those are great questions. I think to even understand why I'm there, I think it might be helpful to kind of get a little bit of a background of where I've come into psychiatry a little bit and how I ended up with the aiming clinics. So I actually trained at UCLA, spent some time also at University of Hawaii, board certified in general adult psychiatry and also child and adolescent psychiatry. On my transition from fellowship, I was looking for different opportunities and interviewed a lot of different places and actually even got a particular job already. And then an opportunity came up with the aiming clinics, and I spent some time researching them, pros and cons, all of it. Spoke with Daniel Emina, Rob Johnson, the medical director, had some really good conversations, and really learned about how they look at psychiatry. It was this very unique perspective, and it blew my mind. It was quite a bit different than how I'd been taught. I actually, by the time I was leaving fellowship, I was a little kind of a little cocky a little bit of like, oh, I'm good. I can handle anything. And then you start going into the real world and you find out, oh, whoa, there's a lot more there. And then you get introduced to what the aiming clinics is doing, and you're like, whoa, I didn't even considered any of this. So initially, I joined on because I was just blown away by the ideas and the way of practicing psychiatry that they do and we do, which has even evolved since then. And now I'm 8 years along. I think honestly, I had probably thought, all right, maybe I'll go do 2 years. It's almost like a fellowship, learn a little bit, then I'll move on. But
Sure.
I kept learning. I kept learning. Each year is a new challenge, a new scale to pick up. And it's one of the reasons I've stayed. I'm now one of the associate medical directors there. And as bringing it back to kind of your question, one of the reasons that I was intrigued by the aiming clinics is we look at the organ we treat. I mean, it seems simple, but
Yeah.
it is a fundamental, but also it creates a significant paradigm shift in the way you treat patients. It moved from these diagnosis and then algorithm to a more intentional, patient-centered plan. So even the idea of seeing that individual's brain, and then which then opens up this mix of, it's like the Pandora's box of like, whoa, this depression looks different than that depression. What does that mean? Right. And
Right.
that question leads you to start asking better questions, right? About things that would naturally lead us into the path of integrative medicine, integrative psychiatry, starting to
Mm.
consider toxicities, considering mold, considering inflammation, other infectious processes, head injuries, and it's kind of just opened up the kind of worms of potential treatment options and treatment modalities. So again, we do quite a bit there, and we'll talk a bit more about it as we go through, but it gives you a little bit of a short intro of what we do.
Yeah, that's really helpful. It's this comment about examining the organ that we're treating reminds me of I think it was a TED Talk by Amen some years ago, where I remember that being kind of a punchline that stuck with me in the back of my head, and thinking to myself, "Wow, I've been a psychiatrist for, I don't know." When I watched that, I was probably like at least 15 years into my career, and I was thinking, I don't examine the organ that I'm treating. Like, it's a really memorable kind of quip about one of many limitations in our field in psychiatry, right? And so I'm so curious to get a little deeper into, with 8 years in, you have enough experience, I think, to comment about like these patterns, like you're talking about different depressions look differently. What are you seeing in terms of, like, are we looking at like subtypes of depression that have different patterns on scans?
So these are
Lead us into that.
These are so good questions, right? So the Amen Clinics, I think, was founded, I think it was either in 89, and I think Daniel Emina started doing SPECT in 91. Okay. And he was super excited. He was so excited he couldn't stop telling people about it. And then the backlash started.
Mm-hmm.
There was that backlash of there's not enough science related to it,
right?
Which is frustrating, because if you literally go on PubMed, and I did this like last night just to like see where it's at. If you type in brain SPECT, you'll pull up at least 15,000 scientific research articles. So there's ongoing research, not just old stuff. There's actually new stuff that's still getting published in the use of SPECT. In understanding the brain. SPECT itself is different than, CTs, MRIs, fMRIs, PET scans, and each modality has its pros and cons. That's just the truth of it. Each modality has its pros and cons. To be like a cardiologist, when they want to examine the heart, the modality of listening to the heart has its benefits. The EKG that measures the electrical activity has its benefits and provides its own unique picture. You might even want to do an echocardiogram and actually look at the heart with using basically sound waves, right? So there's different modalities that provide a different picture and that will influence the decisions that clinician will eventually go about making to treat that patient. And that's one of the things we saw with SPECT, that it provided extra information that allowed us to see our patients differently. The fact that so Daniel Emina, this is way before I ever got there, started looking at the brains, it forced him to think a bit different about psychiatric diagnoses. One of the things that people often think of the Emina clinics for is ADHD treatment. And the fact that he was breaking down multiple subtypes of ADHD. This was blasphemous back then. It was like, you got your inattentive, you got your hyperactive. It was just blasphemous. And then he went even further and said there's different subtypes of depression and anxiety and addiction. And people were like, what are you talking about? And it was blasphemous, right? And it really came of the fact that you can have two individuals that come in and say, I am depressed, fill out a PHQ-9, a HAM-D, whatever depression inventory, come up with a value related to it that qualifies them for depression. But if you actually look at the individual answers, there's like multiple iterations that could have still led to depression for each individual, right? So it's one of the reasons they say depression can be heterogeneous, right? It's not the same thing for each person. And that maps the same way to the brain. It's not the same thing for each person. Different people can present with different looking scans. Yes.
So just for our listeners who maybe not, I want to ask you to give us just a little bit more of a primer on the different imaging pieces that are out there: CT, fMRI, SPECT, PET scan. That would be really helpful. But before I ask you to do that, I want to just elaborate a little bit on what you said about the PHQ-9. So the PHQ-9, for those of you who are listening who haven't heard of that, or you're not familiar with that, is a rating scale that's commonly used in mental health clinics to assess the severity of depression, particularly. It's a 9-point scale. That's why it's called PHQ-9. And you can answer 0 through 3. So 3 is serious symptoms, 0 is no symptoms on each of the 9. So what I hear you saying, which makes total sense to me, is that, one person whose score is, let's say we see a lot of people in the high teens or low 20s, more severe depression, they could have all threes on the first half of their PHQ-9 questions, and then they could have zeros on the second half and have the same score as a person who has zeros on the first half and threes on the second half. And the first and second half of the PHQ-9 is actually really important because, well, at least particularly item 9, which is the suicide question, suicidality. So that has a big impact on how you're going to, treat that individual. So anyway, go ahead and tell us, Daniel, about like what are the pros and cons, just from a bird's eye view of different imaging techniques, and particularly why, you feel like, or the Amen Clinic settled on SPECT over, say, PET or fMRI, for example.
Yeah. The truth, by the way, on what we settled on is that I think there's probably going to be an ongoing evolution of what we settled on, and things may look different. I use the cardiology example for like a very specific reason, because I mentioned that, you might listen to the heart, you might use electrical activity related to the heart, you might image the heart using an echo. You can even do a CT. You can do a lot of different ways of looking at the heart. And those would provide, particular angles and allows you to evaluate the function and health of that heart. But they all answer a particular question. One of the reasons we went with SPECT, it's a mix of reasons. Okay, so I'm going to give a very short explanation of SPECT, because we could spend the whole time talking about just imaging modalities and the pros and cons of each, right? And if you had a radiologist on here, they would even say more and go back and forward and all that. It would be a lot. SPECT, the cool thing about SPECT is that it looks at blood flow. So we're looking at blood flow patterns in the brain. Why is that important? Is that blood flow, for the most part, equates to activity in the brain. So increased blood flow, increased activity. Lower blood flow, lower activity. That's an oversimplification, but it gives you a sense of what the amount of activity you can have in someone's brain. And because there's been so many scans that have been done, at the Amen clinics, we've done over 200,000, but others have done even more. We have a very good idea of what falls within healthy normal as far as the amount of activity you'll see. Now, within healthy normal, you can still present with symptoms. You can still technically get depressed or have anything, but the likelihood of it is significantly lower, right? So if you fall within that healthy range, you're less likely to present with a symptom. Above that range, maybe more likely to present. Below that range, maybe more likely to present. So within that healthy range, less likely to have a concern. Outside that range, more likely to present with a concern. The thing is here, it's specific to the area of the brain you're looking at, right? So if you're seeing decreased activity in your frontal lobes, there's a mix of symptoms you may present with, right? More inattention, more focus-related concerns, more impulsivity-related concerns, even certain types of depression and such may even impact your ability to be as empathetic, right? Depending on what patterns we're seeing in your frontal lobes. Increased activity in the frontal lobes can even be problematic. Increased activity in certain parts of the limbic brain can be problematic. It just matters where it's showing up. Now, when you start using one of those modalities, you get good at using that particular modality. So, in this case, SPECT, you just get good at it. You build a database of it. You know what it can do and what it can't do. It might not see everything, but it can, it can see enough to allow you to ask the questions you need to, and it prompts the workup you may need to eventually, start. So SPECT, again, is looking at blood flow. MRI, different mechanism of how it does it. And I'm going to leave that to the radiologist to explain, because it's usually quite a bit harder to explain MRI. And on top of MRI, there's something else called functional MRI. MRI usually is more focused on structure. So looking at the structure of the brain, it's using the magnetic properties of pretty much all elements, or even in our body. In particular, is looking at like oxygenated versus deoxygenated blood. So there's that piece, but it's looking at structure in general. Now, there's another algorithm that's run for fMRI, which is functional MRI, which is looking at activity patterns. So that's actually one of the biggest areas of new research, is using fMRI to do some of the same things we've been doing for the last 30 years or so. PET is another way you can look at activity levels too, and that's more using glucose metabolism. There's some other ways you can get PET to work too. PET is pretty much the priciest, tiny bit more radiation. MRI, no, none as far as the radiation is concerned. You do get a bit of radiation with SPECT. And there's obviously not necessarily the last one, but one of the other ones is CT. And that's one of the ones you go into the ER, you broke a leg, you had a car accident, they'll scan you up from head to toe, right? For the most part, that still also ends up being structural, even though there's other variants of that you can create a functional picture with. So why did we go with SPECT? Because one, it was more accessible. Pricing wise, it actually still, even though it's very expensive for those machines, it's still quite a bit cheaper than an fMRI. It's still quite a bit cheaper than a PET scan. And its ability to, it's not as finicky in some ways. Some of the reasons people actually criticize SPECT is actually some things that work towards its strengths. The way you're able to do the image, the timing from getting the tracer to when you can actually even still complete an image. Quite a bit of some of those things actually allow us to get the images we get and get them more consistently. The fact that we have our own clinics and we train our own readers, and actually we've built out our own reading software, and this is more of a machine learning based reading software, which is really one of the things we're building on, and super exciting right now. So we're having very consistent results between readers, irrespective of who's reading the scan. Right. So short answer there, we went with SPECT because one, it had become more available. There was a lot of cool research on using it in psychiatry. We built up a strong enough and large enough database that we now had a good understanding of what it meant for our client base. And as we were doing the work, and this is Dr. Emina, as he was doing the work, you started to see the benefits of it come through. So I know I'm being long-winded here, but I'll give you an idea of what I mean here. SPECT really comes down to, do you see good activity in that brain? Does it fall within that range? Right. And if not, is it too little? Is it too much? Based on that, then you start asking yourself questions. Well, why am I seeing this particular pattern? In the why am I seeing this pattern, that just drastically created a paradigm shift in how Dr. Emina saw his patients. Because now he started looking at why is that there? What does that mean? Which actually opened up the door to integrative psychiatry, because we started to see, wait, this person has Lyme disease? Interesting. That's an interesting pattern. We're starting to see that. Wow, and the people that have Lyme disease, they tend to have this particular pattern. Oh, substance use, cannabis, weed. I thought it was healthy and great for the brain and everything. Whoa, well, look at this pattern. Mold, environmental toxins. One of the first big ones, was the head trauma in particular, right? Seeing that having head injuries was not a benign thing, right? I just had a new evaluation this morning, a young kid, 13, and no one can remember the head injury. But as we dug a little bit deeper, you're like, well, there was that one time that you fell and hit your head on the wall, and we can actually see this on the scan. You're seeing decreases cerebellar. You're seeing decreases on the prefrontal cortex. You're seeing even a slight change in the angle of the cingulate, which is a part of the brain too, that almost looks a little bent. And they didn't remember that.
Wow.
Head injuries hurt people. That's actually one of the biggest things I've seen working here, is even small head injuries will have a significant impact on people's lives. The injury that they fell, they're 9, 10, 12, 13, all of a sudden they can't focus as much. All of a sudden people are going, you're lazy, why aren't you getting your work done? And it changes their lives, right? Just that little head injury. But again, you start asking these questions, you start going, well, someone has a head injury, what do you do about it? Can you treat a head injury? All right, let's see what we can do. Let's throw a bunch of things on it and let's rescan them and see if it changes anything.
Hmm.
Wow. Oh, it did. Now that helps us refine our plans and our treatment plans, right? Other things like hypoxia, anoxia injuries. Another big one I learned was sleep apnea is not benign. It shows up even years, decades before. You can start seeing these decreases, especially in the parietal lobes and longitudinal fissure. I jump all over people now if I see that pattern. I'm like, did someone tell you snore? Yeah. Did they say you have sleep apnea? Yeah, but I can't stand the machine. I'm like, you're gonna get dementia if you don't treat it.
Hmm.
Right? They could be at 40 or whatever it is. You can, and you start seeing those decreases there. You treat them differently.
Mm. Wow.
Infections,
Early
hypothyroidism.
detection, right?
Early
Yeah.
detection is huge.
Yeah.
So quite a bit there. It becomes this decision support tool, and I could, as you see, I could talk about it for days probably.
No, I love it. It's so fascinating. And of course, probably a lot of people listening are familiar with some of the let's say naysayers or critics, or, it's not ready for prime time and so forth. And it's kind of hard for me to argue with 200,000 scans and developing a database in the very same way that neurofeedback, which is widely accepted, has a database that's based on, if not hundreds of thousands, millions of, brain scans, and defining what's normal, what's the bandwidth of normal, what's the range, and then what are the patterns you see. And so why not SPECT scans if neurofeedback is so widely accepted and even covered by insurance in some cases and so forth? Yeah, makes perfect sense. But the tool is obviously a lot higher resolution. Am I right about that? And I mean, SPECT versus that brainwaves, electrical brainwaves.
So really good question there, because that's one thing that can come up as far as like resolution on the different tools, right? fMRI, really, the what's called spatial resolution is really amazingly small and acute. The temporal resolution, the timing of the changes you can pick up is really, really acute. And SPECT has its timing, temporal resolution and spatial resolution. Even neurofeedback or excuse me, EEGs, QEEGs have their own benefit of what you can pick up. Each thing provides its own picture. I really do eventually believe we'll probably have some combination tool in the future where we look at the brain in different ways. It might include some version of an fMRI, some other version of a SPECT. My own personal thoughts are that fMRI is almost too finite. It's almost too good at picking up small changes that I think even being anxious while getting the scan can impact it. Even a bus, I mean, there's actually stories on this. There was like, I think there was a subway going by. There was some paper that was published, was creating an artifact in the fMRI data.
Oh, wow. That's data. A very sensitive tool.
It's so sensitive that it can impact things, right? We have a little bit more leeway with SPECT and what it does. So even though its temporal resolution may be a little different, it does still allow us to almost gather. So its temporal resolution is more in the minutes. So it gives us more of a sense of like what's the brain like over time, not just in these milliseconds of changes, right? And in that's helpful to us too.
In those minutes of time, is it part of the routine to assign tasks inside the scanner to see what happens?
So great question. So we attempt to do 2 scans usually for most individuals. We do a resting scan and a concentration scan.
Got it.
The resting scan is they get the tracer. The tracer goes with blood flows to the brain, settles into the brain, and starts to emit a gamma ray. That gamma ray is what's picked up in the camera. So at camera level, there's not much going on beyond just picking up that high energy gamma ray that's released, right? So by the camera, they just have to sit still for the most part. On the resting scan, we have them sit still, not do very much. On the concentration scan, we have them do a concentration task, and this is standardized for all the patients. It's a Conners performance test. right? So it allows us to compare individuals to individuals because it's the same test.
Right.
And that allows us to see the brain at rest and the brain concentrating for our individuals. And that helps us figure out things like actually there's certain things that show up a little bit better in concentration, like ADHD. There's certain things that show up a little bit better in a resting state, maybe earlier signs of like dementia, earlier signs of toxicity. There's certain other things that we might see a little bit better on a resting scan than we might see in a concentration scan. So we like getting those two pictures.
And if the presentation was, let's say, PTSD, do you do a different kind of? It comes up for me thinking about, if you put someone's attention on a traumatic event and they have PTSD, you're probably going to see a massive shift in blood flow. Is that part of or you just do the Connor's task and the concentration plus the resting for everybody?
Yep. And this is the beauty. This is, again, why I think this is, for some people, they think of it as a limitation of SPECT, but I actually think it's a benefit of SPECT. Because of that temporal resolution, there's an element of just capturing what the brain tends to just be like. Right. Whereas it's almost like not necessarily a pure resting state, but what's its baseline concentration state? What does it normally just fall back into? So, for instance, you mentioned PTSD. There's a diamond pattern, a diamond plus pattern we tend to see. And it's the combination of what we'll see from cingulate activation, basal ganglia, bilateral basal ganglia activation, some thalamus activation, and some activation that's usually into the insula. And we'll pick up that particular pattern, and there's usually a higher risk that that person has experienced PTSD. I think of it like this: their baseline limbic state is just elevated. Their threat detection is just elevated. It's just always looking for something, right? Irrespective of they're thinking about it or not thinking about it, it's just elevated. And it's a powerful tool when you can show that to somebody and be like, it's very validating. It's actually probably one of the biggest parts of the scans, validation that people feel. They're not just crazy, right? It reduces the stigma. It makes it a medical thing, not a moral thing. It's not a weakness. And I think it's one of the reasons why people continue to come to it and look to the clinic for those SPECT scans.
Now, speaking of destigmatization, it kind of takes my mind to another topic that you and I have explored before, is the issue of suicidality and just how much more intense things are for people since the pandemic and post-pandemic, and particularly so much going on for teenagers, young people. I've seen just a massive spike in suicide attempts and suicidal thinking, and brings up for me a question about, again, I'm coming from a place of almost total ignorance with regard to SPECT scans. So I'm curious about whether in people with a lot of suicidal ideation, do you actually see a pattern in the SPECT that is reflective of that, or kind of consistently or typically present there?
Spectacular question again. Just as we discussed with depression, anxiety, ADHD, there are types. There's almost subtypes of everything, right? And even with suicidality, there can be different subtypes, right? And we've published on this, and others have published on this using other neuroimaging modalities. And from our perspective, the things that we will see in our studies, which actually mirrors and overlaps with the other studies externally, there's the tendency to seeing decreased prefrontal cortex activity. Okay, remember that's attention planning, follow through, but it's also problem solving, right? And there's also a downregulation that happens between that prefrontal cortex and its ability to regulate that limbic or emotional brain. Right? So there's that. That we'll see some level of dysfunction. When I talk to clients, I'll label it like the temporal lobes. but there's actually quite a bit that's occurring at the temporal lobes. There's the insula, there's the amygdala, and there's even the interconnections and such there that come through there. But we'll see some level of disruption, whether it's injury to that area, decreased activity, or actually the opposite, sometimes increased activity. Whenever I see that pattern, I'm already going to be more concerned about more impulsive aggression, right? So
yes.
frontal lobes are down. I'm seeing parts of the amygdala potentially being elevated or increased in activity. I'm worried about that amygdala overwhelming that frontal lobe, right? Because we already know that happens when we get upset. There's a tendency our amygdala rises up in activity and our frontal lobes come down in activity. And part of therapy is actually improving our ability to self-regulate by boosting that prefrontal cortex activity so we can regulate that emotional brain, right? So we do that through different types of therapies, but even just naming the emotion actually starts that process of regulating it, right? So we'll see patterns like that, and it doesn't mean that we'll use it in itself to just predict that you're going to be suicidal, but it does tend to overlap with people who come in with the concern of suicidality. Now, here's where it's important as like a clinician. If I see that pattern, and let's say I see a teen and there's depression and anxiety, of course, part of my workup is that I always have to ask those questions, right? I have to ask, hey, you had those thoughts?
Sure.
Because it's actually more important to have those questions, have the discussion. But if I see that particular pattern, I'm in the back of my mind, even if they haven't had the thoughts, I need to make sure that I'm creating a plan that would potentially manage those thoughts. What am I doing to regulate amygdala activity? What am I doing to support prefrontal cortex activity in the plan? To be even more specific, this will change how I sequence, whether it's supplement recommendation or medication recommendations. One of the things that's been noted is that, and this is not, I mean, it's controversial, but it's something that's out there. It's in the data that sometimes when teens, especially young adults, they start taking an SSRI, there's actually an increase in suicidal thoughts.
Sure. Black box warning. Sure.
It's a black box warning. It's right there. And it makes sense when you start to understand how these meds work and which receptors they may be hitting, especially when they increase serotonin initially, what it's actually doing. You get that overactivation at the serotonin 2A receptor, and sometimes that can lead to aggression. So that will influence my plan, right? I would say, okay, I see this on the scan. We like to do genomics. Maybe I see that they have a serotonin 2A receptor variant that would put me to like watch out a bit more. So I may be more likely to start with something that's mood stabilizing, even if it's just a supplement, whether it's a GABA or lithium orotate, or even a gabapentin or lamictal. If we do go use a med, obviously in combination with omega-3s, changing up their diet, avoiding sugar, getting a bunch of healthy fats there, because that's supposed to support the brain. Before I bring in an SSRI or a SNRI, some other med option, because I know those can destabilize that area. So I need to make sure that I've done enough to stabilize that area before I do that next step of maybe the antidepressant.
That's a great example. Yeah, I like that. Yeah. Makes sense. Laying down a foundation before you potentially, outside the context of the foundation you laid, it could overstimulate and further exacerbate frontal disinhibition that may be there relative to the activation in the limbic system.
Exactly.
Yeah. Wow. I want to ask you a weird question.
Sure.
And maybe it's not weird, but I'm wondering if you now, hopefully you will never need to do this, but let's say, SPECT scans went down, you couldn't do specs for a year or two. How, it sounds like your experience over 8 years has set up a way of thinking about what is being presented in front of you that's not going away. Even if let's say there was a blackout or something and you couldn't get a scan for a couple years, now you see patterns, right, in the presentation of the patient that the pattern recognition doesn't go away, even if the if you're flying blind for a while, so to speak, without the scan, would you, well, I see you answered the question already, nodding, but it sounds like the way you would treat patients would not change, because you have this formulation, and the way, the lens of seeing what's in front of you is just what it is after this experience.
Yeah. So again, another great question, because this is literally one of the reasons why I've stayed at the clinic, and I continue to enjoy being here, and I want to be a champion for this type of way of working with our patients and just the patients in general. First, I always like to focus on the fact that we want brain health, right? It's not just about mental health, or it's about brain health, right? Can we own that? That I think that's one of the foundational changes doing this type of work and being so focused on the brain. Now, the truth is, I know we're talking about it so purely on biology. The truth is, it's not just purely about that too. That's the other thing, and doing this work has taught me. I've learned that people drive their brains differently. And I'll give you an example here. Imagine if you gave everybody an identical car, and say you race around the track, and they do this in racing, right? Relatively identical cars. They will drive their cars differently, right? We all drive our brains differently, and we relate this to maybe our experiences, the skills we've gained over time. There's some elements of our personality that impacts how we drive our brain. So yes, two individuals may come in with, now let's say, similar diagnosis and similar brain scans. So it's not that they're completely different. Similar diagnosis, similar brain scans, okay? But one individual might have more challenges with their particular diagnosis. Why? In the context of their environment, in the context of their skills, in the context of how they perceive themselves, their interior narrative, how they're perceiving whatever the illness and such is. It will impact even how they do on a treatment plan, right? So,
right.
Even though
for example, what your father said to you about your limitations, or what the teachers said to you about what it means to be, let's say, dyslexic, or whatever the situation is. Yeah, got it.
Exactly, right? So that piece becomes important. So I'm thinking, all right, brain health. I want you to love the brain you have. Work towards continuously taking care of it and refining its health. Want you to have a good understanding of what your brain is good at. That's actually, again, one of the things about doing this. It's not only about saying, oh, wow, you got too much activity here or too little here. It's like, oh, having that extra activity actually allows you to be better at analytical thinking and creativity, and your level of empathy is through the roof. But it also means you got to take care of yourself. You got to be careful about who you're interacting with and the relationships you're building, because you're going to carry some of that emotion. Right. So we try to speak at it in that balance. And then what you were getting at earlier was that because of doing this work long enough, based on presentation, based on the way they describe things, I do tend to get an idea of what I believe is going on. I actually pride myself in trying to almost imagine what the brain scan will look like before I look at it. I still do get surprised at times. That's why we do it still. I even add another level. We haven't talked about this, but there's some how genetics and genomics can kind of impact how the scans look a bit too. So I add that little bit of a level. I'll be trying to okay, I think I know what may be going on here. We'll test it to be sure. So yes, even if we didn't if I didn't have it, we didn't have it, there would be other ways of practicing, but I would be definitely missing this tool.
Yeah.
And let me take even a step further. I think, neuroimaging was such a controversial thing in psychiatry, but even the biggest centers now are using neuroimaging. They're doing studies on it. They call it, they're related in their precision psychiatry departments. They'll combine neuroimaging, genomics. Right. They'll combine it with big data and analysis, and they're creating subtypes of depression. Things that Amen Clinics was laughed at for even considering in the past. And now we're recognizing that, hey, that really is a thing.
Yeah. They say in medicine, first they ignore you, and then they ostracize you, and then they accept and reify you, or something like that. The 3 steps of advancement of medical knowledge.
Yeah.
Oh man. Well, I'm curious about this piece you were talking about. You've alluded to that we wanted to get to today is this piece about correlating different databases, and especially around the genomics piece. And I wonder if you could tell us a little bit about, what you've learned from running genomics and specs on, sounds like quite a few people over the years. And those of us who have used a lot of genomic testing, it's fun to think about and predict, like you were saying, what do you think is going on with this person and their comp status, or how are they processing dopamine, the frontal lobes, et cetera, and then get the test and get surprised or not surprised. But I'm wondering what you're seeing around that, and are there, once again, patterns that confirm or don't confirm these genetic variations that a lot of people are running pharmacogenomics in their clinics, but most people that I know are not. You're the only person I know who's running specs in your work. So tell us about that. Tell us about those correlations.
Yeah, genomics is, myself and another colleague at the clinic were like big proponents. We just actually had an Amen Clinic doctors conference, and we did a presentation on genomics and what we were seeing, and continue to encourage more and more people to use it and become more comfortable with it, because it is the future. It's a present, but it's also there's the future in it too. I don't think we know everything, obviously, in relation to it. It just continues to evolve. I remember when I first started using some genetic testing and training, I think we were looking at just CYP 450 genes. So we're just looking maybe like 6 genes or something. And then we've added and added and added. Some of the tests have 24 genes we're looking at. Some have more, depending on how you got the test done. But it's really, really an exciting field, and especially when you're able to correlate it with scan data. This is actually something we're attempting to do internally too, and maybe partner in the future. But we have in our research team, and we have a very skilled data analytics researcher who's going to be helping us make some further correlations. But I'll give you an idea of what that ends up looking like, right? So you mentioned catecholamine methyltransferase, or COMT, and the SNP status there, if they're met, methionine, or valine, and what that can potentially mean, right? We each have one copy of each. The MET, what was what we would call them, would be a slower metabolizer, so they would break down dopamine and norepinephrine slower. Val would be faster, and Val-Met would be moderate, or in between. Most people end up being Val-Met. The funny thing about it is that being on the extremes of anything just gives you a smaller operating window, but it's not in itself a problem, right? So you can be Met and perfectly fine, Val and be perfectly fine. Okay. It's just a smaller operating window. So if you have a head injury, my valves may tolerate it less than the Met. Why? Because they burn down dopamine, norepinephrine quicker. There's a tendency when you have that head injury, it's harder to turn that brain on. So you need something to kind of turn it on. And now you already burned through dopamine quickly. You already had an issue turning your brain on. So it's going to be a little bit more of a challenge to get dopamine to that frontal lobe, right? So you're going to be thinking about what's stimulatory for them. The truth is, even on the other end too, the Met individuals will also have some issues at times. The scans may look a little bit better because it still looks a little bit more plump and active, but they will still have issues regulating those pathways. Now, there's other patterns we'll see in relation to it. It might impact, yes, frontal lobe activity. I've seen it impact limbic activity. So the limbic brain, just things are just more active on people who burn down dopamine and norepinephrine slower. Are there benefits to having more dopamine and norepinephrine? Yes, there's potentially language benefits, executive function benefits, versus individuals who burn it up, quicker. So there's pros and cons to either, and you have to be aware of what those pros and cons would. I'll even add that it even impacts things like your estrogen metabolism, right? So if you're comp met, you burn out estrogen slower than someone who's comped val, who moves through estrogen. So understanding your hormones becomes important in this. If a woman has a head injury in the past, that can, and depending where she's at hormone-wise, that can impact things. If she has PCOS, definitely impact things too. If she has PCOS and she's met, right? So you can have these kind of very high estrogen states. So now they're foggy, the mood is off. So it becomes part of the treatment plan, right? It's not just give them an SSRI. You might need to, but you might need to do other things to support them hormonally. You might need to do other things to support comp activity.
Yeah, great example.
Yeah.
Wow. Yeah. The knee bone's connected to the thigh bone, I guess, with all of these integrative aspects of care and health, really.
Yes.
Yeah. So, wow. And so would you say, I'm curious for, again, for the folks who are maybe practicing in more conventional settings, maybe they're in even, qualified mental health centers, public clinics. Do you feel, has it been your experience in working with these tools, particularly genomics and SPECT? Have those tools helped you rely less on pharmacology to get the results that you're looking for, do you think, with your patients? I'm just wondering I'm thinking about my own journey and sort of over decades of, gradually, never eliminating medication. I'm not negative on medication. I think medication has a really important role in the integrative psychiatry toolkit for sure. And it's critical for some people to function. Having said that, I definitely prescribe a lot less benzodiazepines and less antidepressants over the years as I've learned about these interconnected webs of health that we have to support to feel good. So yeah, I'm just curious about that as far as your experience with, coming out of fellowship, and has there been a shift over time in terms of going less to pharmacology with your treatment plans?
Oh, 100%. One of the favorite things about this work, and again, one of the reasons I've enjoyed being at the clinic and continue to be at the clinic, is that I love adding tools to the tool belt. And all of this, the fact that we can, have a better assessment and understanding of the person individually, their brain, their genomics, their gut testing, their hormones, whatever it may be, it means that I can be more targeted in my treatment options. Right. And it's not just, all right, well, let's try this other med. There was this new med I heard about that might help. And those, they might help, but it doesn't necessarily mean that it covers all the mechanisms that individual needs to target, right? If their testosterone's too low, I got to treat that too.
Right.
And frankly, that means I can keep them at a lower dose of the med if I did have to give them a medication, which then means less side effects. It maybe gives us an opportunity for eventually be able to titrate off the med because we got their brain healthier. It just completely, and then they see the med as the tool that it is. It's a hammer. Use the hammer when you need to use a hammer, fix the thing, work on the thing. Some people, yes, need to continue to use a hammer or something all the time. Some don't always need to use that particular tool forever, but they need to maybe use others. And some of those others may be more natural, easier on the body in the short and long term.
Yeah. 100% agree. And trying to get to, wherever possible, getting to the root cause of what, like, for example, the person with low testosterone, do they have sleep apnea? Is that what's driving the low T, as opposed to, it's menopause or whatever the other diagnosis might be. So not just slapping T on somebody and not doing a polysomnogram to try to get to the bottom of it. Yeah.
Or identifying the head injury that they did have, because we see that a lot, right? They have a head injury, they forget about it, they thought it wasn't a big deal. You see it on the scans, you do the labs, you see that their hormones are low because they're basically hyperpituitary all these years. they're depressed. Someone's been given an antidepressant. They came to see us because they were depressed. And then we find out, hey, you had sleep apnea, you had a head injury, your testosterone is low. Okay, let's treat your testosterone, but you got to start treating your sleep apnea. And regarding your head injury, there's tools to actually help your brain heal, even though this is an old head injury. Get an HBOT, do 40 sessions, right. 60 sessions. One of the questions that I think we discussed over email was that, yes, the brain changes too.
Right.
So often we'll have people, especially going through a protocol like that, come back and get scanned in 6 months or a year or something, see your brain change. That's very encouraging. Right?
Absolutely. To see the change. Yeah, absolutely.
Exactly.
Yeah. Well, this is so much fun to rap with you about these topics. I could go on forever and ever. One thing that we like to ask our guests as we start to wrap up is if you had access to a billboard that you could put a one line on that everyone in the world would see once, what would you want them to know? What would you like to say to them?
That's a deep question. And yeah, I'm a person of faith. So it usually ends up, it's going to lead into a more faith-based answer, but I believe that and this is, it's going to be longer than one sentence, but I have to find a way to make it shorter.
No problem.
I believe that every one of us matter, and we all exist on this earth for a particular reason. It's not the same reason for everybody. We don't need to accomplish what the other person accomplished. We had our particular journey. And yeah, I do believe that, again, being a person of faith, I believe there's a God that cares about each and every one of us. So I think in this journey, it's about discovering what's our journey, embracing that and appreciating that journey.
Beautiful. It's deep in the heart, Daniel. Thank you.
Thank you so much, Will. It's been a blessing to be on again.
Thanks for being here.
This is awesome. Thank you so much.